more shock on the table, so we are better prepared. Our implants inventory is better prepared because of this modern investigation. They have helped us a lot to plan a surgery and give a perfect job. In fact, the father of the pelvic surgery, Joel Mata, it's one of his statements in orthopedic that we believe in perfection and excellence will be tolerated. So we believe in that nowadays. We have come to that era. So all these fractures, intra-articular fractures, you cannot diagnose on X-ray. An unstable patient will be in a difficulty. Kind of fractures because 3D CT scan. So this about investigation. Then there was a tremendous improvement in the treatment schedule, like treatment modalities. Like we don't open the fracture. We know that the tissue around the fracture, if we keep the soft tissue intact, the circulation intact, the bone will heal faster. So we treat the patient with minimally invasive plate osteosynthesis, MIPO, and close intramedullary nulling. Plus sometimes we do arthroscopic guided surgery. Okay. So as we know, there were old plates before 60s and 70s, which used to be round hole plates. So we invented new plates, which were titanium plates, so which have the same elasticity of modulus like the bone. So there is no fatigue failure of the implant, and the bone would heal faster. Plus there were pre-contoured plates, okay, and locking plates. In osteoporotic bones, the screw would lock also on the plate as well as on the bone. So it would not loosen, it would not walk out. So in porotic patient, in senior citizen, we used to find that we have done a perfect job. And after 1 month when the patient comes, the plate is flying off. So because of all this modern inventory, okay, we have a lot of new things in our armamentarium. Our modern inventory, like this, pre-contoured anatomical plate, we can treat these fractures on day 1 and patient can walk on second day. These are some of the examples, illustration of the contoured plate. We don't have to, the inventory has increased, but it's like almost like playing a mechano on table. Everything is pre-contoured, huge inventory is there, and we can fit the patients it perfectly to the patient's bone. So no more bending, contouring. You know, this operation is going to be with minimal soft tissue injury, and we can get results like this nowadays with complex fracture. Okay, or fractures like this, where in 10 years ago, if I was not knowing the MIPO, minimal invasive plate osteosynthesis, I would have thought that surgeon has forgotten to put few screws. But now knowing the bone physiology better, and this is a MIPO technique, that plate has been slided over the fracture and the multiple segmental fracture is there. I know that the whole of the bone biology is preserved by the surgeon, that is me, yours truly, and fracture has landed up in union. Suppose if I had opened this whole fracture, all those bone pieces would have come into my hand, they would have become sequestered. So almost with this inventory we can treat every intra-articular, juxta-articular comminuted fracture with ease. Calcaneum fracture, which where people used to be limping lifetime after this fracture. Now we can raise the articular cartilage and we have the multi-hole pre-contoured plate. Okay. Now see the example of some MIPOs we have done. You will see that the plate is long but the screws are minimal. Plate is elastic, it's an elastic fixation, biological fixation. And if you see the incision of this patient, there is just two stitches in the proximal end and 2 in the distal end. Whole of the fracture is not open. Similar in other cases like this. So you can see the stitches, only few stitches mark are there. The basically fracture is not exposed. The concept is biological fixation. Another most common fracture, it's like almost used to be like a death sentence for our senior citizens, hip joint fractures. We know that in good old days the patient used to be on traction for 4 months, and lot of them used to succumb to the other problems like pneumonia and bed sores. So there is tremendous involvement in the treatment of the fracture because of better understanding. No more we use this fixed angle plate because they used to break. Okay. No more we used to use extra medullary plate because they are eccentrically loaded and they used to break. So what the concept is now, to have intramedullary device. They are the load sharing device. Okay, and they can be introduced again through a small incision. I will show you example of this. So these are the first generation intramedullary nail with screws. We found that even the old people, the screws walk out very fast. So we have gone for the contoured plate or a contoured plane, that is called a spiral blade. So it is no more rotated like a screw, it is punched in, tapped in to the bone, and the pull-out strength is very high. So very useful in osteoporotic senior citizen patients. So this is an example of that. This is a photograph of this new design, and this is an example of this patient. See the number of stitches, only 3 stitches in proximal end and 3 for a distal interlocking. So no blood loss, patient goes on 3rd day, and patients like this previously would have been nightmarish experience now can be treated with ease and a walking full weight bearing. Again with the new implant patient like this, where surgeon will be putting his fingers in his mouth and telling the patient this patient is not going to unite. Now we can treat with ease with the modern plate, titanium pre-contoured plates, and they can have healing very fast. Again segmental fractures like this, like there was no answer for us. We can treat with the pre-contoured plates. Okay, so we have moved from a rigid fixation to stable fixation to now biological fixation, because bone is unique, it replaces itself. It is not, when skin heals, it heals by scar, but when bone heals by another bone. So a surgeon can delay fracture healing by interfering with the nature, but now modern surgeons, this generation surgeons, we have evolved thanks to the better knowledge and development in the field, that we are having healing with a biological fixation. Another important part which Dr. Vaidya has already talked about, the role of joint replacement. I will preferably talk on the role of joint replacement in the fractures. There are some fractures which cannot be helped even with this kind of modern inventory. So whatever we cannot repair, we have to replace. Okay, like fractures like this. Good old days we would have thought of fusion because there was no answer. But now with the modern era of joint replacement surgeons, good surgeons like Dr. Vaidya and me, that we can actually replace this joint and patient can have normal knee. Okay. Plus, we have better facilities. We all know we are putting huge implants inside. So we have better facilities like laminar flow, operation theatre, where the surgeon can do the best of the job. But a disaster would happen if there is an infection. So infection rate in early joint replacement days was very high. Now with modern facilities and these goods which we wear during operation, here our breath doesn't go on the patient's body, and the bacteria which we shake doesn't go on patient's body. Plus whole OT area is recycled 15 to 30 times an hour. So OT is virtually bacteria free and particle free. So with all these facilities and newer techniques like this hyperflex design which I discussed, mobile bearing, then designs to suit gender and race, because even male and female the bone there is a slight geographic, slight difference in the morphology. So with all these new things, plus oxynium zirconium coated joints, the fracture, difficult fracture is another part. Again he has showed some cases of rheumatoid arthritis. Typically rheumatoid patients come very young, 25. The youngest patient which I operated for joint replacement rheumatoid is 22-year-old. So these people are typically bedridden. And good old days they used to be dying in the bed because nobody had the answer for them. And we also as an orthopedic surgeon we would be hesitant to offer them joint replacement, because I know that our initial joints used to last only for 10 years, 15 years. But now even in that era, I talked about the facility. Now in the material, the majority failure is to be because of the wear, loosening and wear. The polyethylene has changed. Now we use highly cross-linked polyethylene. Then we have zirconium joints, which FDA, US FDA has given an approval for 25 to 30 years. They have certified that. So of course, we have to combine these for the best of the patient and use the most appropriate implant and prosthesis for the patient. But at least this inventory armament is available so that we can think of doing joint replacement in younger patient and hope that how his patients that joint is outliving. That is the ultimate dream for a joint replacement surgeon, that his joint should outlive the patient. Because the patient should never require the second joint. It's the ultimate success story for a joy for an orthopedic surgeon. That patient's joint is living lifetime. So people like this, road accident, operated, had a very bad arthritis because of AVN. Young patient, 32-year-old lab technician, because of the modern inventory like uncemented joint, ceramic joint, we can offer joint replacement and see the happy result of these procedures. Okay? He is climbing without any stake. Otherwise this patient